Good morning to our viewers and the panelists for this exciting event of Meet the Masters. Is actually 12th. We have been doing for 2 years now. And for our moderator with Sanjeev, Sridhar, and Preeti and others, I'm just trying to see all the names, those who are. But let me start with the case presentation, and we'll have a lot of discussion about and so. So this patient, of course, I was guided. Theme today is I was guided rotational atherectomy for plaque modification, and so this is the case. No, sorry, we have to change the case actually. It need to be a case number 12. Just 1 second. Can we take from different one? Okay, you can just talk a little bit. I got the wrong one. I thought so.
This is a good guide, right? Go. He's bringing the slides, right?
Yep.
Meanwhile, you need to show the case before we even start talking, before I show the angiogram. I guess we can show the angiogram. Goal, can we? Okay. We can see the angiogram. So this guy, 87-year-old with the multiple risk factors. If you see, one only good thing is this EF is normal, but otherwise, AFib on good therapy has been on aspirin, Plavix, and Eliquis for AFib. He was here a few months back with symptoms, CAD symptoms, and at that time was diagnosed to have 3-vessel CAD. You got the slides, SS?
Yeah. Sorry, but updated one. When you put into the key, same names, updated one will come. So basically, this is the patient who had a 3-vessel disease, but I think I want to show it. Are we ready now? But angiogram you have seen now, right? We are not, okay. Yeah, so this is our case number 12. 85-year-old, lot of PADs actually have a venous as well as arterial stents in the leg. And the risk factors are shown: medical therapy, recent angina, AFib, also on Eliquis, basically, and was found to have 3-vessel. With the age, heart team discussion felt PCI is reasonable and had a PCI of the LAD2 lesions, and we are now going to do the RCA, very angulated calcific tortuous right coronary artery with a 2-vessel disease, as you can see here, is still appropriate. In this particular case, and it's a calcific lesion. So we show now.
Fine cross.
Yeah. So we are ready to show the LED was good. We always see what you had done before. The 2 lesions of the LED. Circ is still there, but look at the calcific RCA. That's the goal of today. It's one of the tortuosity. And while we are trying to work it out, a lot of people will say, well, this tortuous lesion, rotational atherectomy is contraindicated. But at the same time, IVL will be a very tough to deliver. So IVL will not go that far. We all know with the tortuosity, you need to, if you even try to go IVL, you will still probably need some kind of a plaque modification, whether just a high pressure balloon will be good enough using guideliner and Gardzilla. That's one possibility. But we thought that this is a good case with a moderate plaque modification using maybe 1.5 rota bar, and then combined with high pressure balloon dilatation or cutting balloon or IVL. So that is the goal. So with that note, we are just going to start now. Another problem in this patient is patient has a stents in the vein because has a Gray Turner syndrome, and putting a pacemaker from the leg is a little difficult. Although we can go from other side and try to navigate, we felt that this is a case where we try to do a non-pacemaker issue, because you'll need a definitely there will be a lot of bradycardia and asystole in this particular case. We can predict that, but give the combination which we did long time ago, 90s, and I know it has been surfacing, and we do many cases like that now because of the radial. You don't want to have a pacemaker. Give a combination of aminophylline and atropine. So aminophylline is 5 milligram per kilogram, 300 milligram you give it before your main rotablation, last about effect around 8 to 10 minutes, and with atropine. So this is what we are going to do in this case. If it's still patient very symptomatic, then we had to try to navigate the pacemaker from other side. We didn't want to puncture it. Patient was on because of NOACs and these patients have high bleeding risk. So that's where we are. And maybe if somebody else has experience, I'm very confident this combination of aminophylline and atropine will be okay. And maybe we can ask our panelists, Sanjeev and others, that what they feel in a complex rota. Simple, I think you can okay, but you saw that tortuosity, angulated, this one will generate a lot of debris, even with a smaller burr. And that take care of this the issue about the asystole and so.
Other problem, he has a creatinine which is 1.9. Yeah.
Okay. So we'll be more careful in giving the dye in this particular case, although last time his creatinine was 1.7. Yeah, it's 1.6 has gone up. Yes.
Yeah, Dr. Kasturi, so what's your opinion in such a badly calcified artery? It's a long, tortuous, and definitely there is a chance of bradycardia. So what is your experience in your cases about the...
Yeah, good morning. Always it's a great pleasure to watch Dr. Samil Sharma and Annapurna while doing case, because they are very great teachers. They are contributing a lot to academic, particularly in that interventional cardiology. I feel this is a very high risk because the very highly tortuous like epsilon, multiple curves, and distally there is a very tight lesion. While you are doing the proximal ablation, because the distally there is a tight lesion, debris can occlude, it can lead to more. I also anticipate backup is not adequate.
Give us 8.75.
So
Mark,
I feel
has to be
patient may require the Impella support.
Yep.
And if Impella support is not there, guide law or telescope or whatever guide extension cath is also sufficient. But actually, practically, we have to be very careful while dialing, slow taking movements, and they are all masters. They know everything what to do, because you asked my opinion. But if you are while doing proximally, because distally there is a very tight lesion, there is a chance of slow flow, no flow very high, and in such case, I feel most of the time we keep balloon tip pacemaker while doing such dominant right corner, which is very large vessel. And IVL, as you mentioned, definitely deliverability is a problem. But with it is also possible. You can put the guide extension catheter like an inchworm technique. You deeply ablate step by step. That is also you can do. Another thing is orbital usually, though it's contraindicated in highly tortuous lesions because it may lead to some perforations, but careful it can be done. Rota, I personally feel distally because very tortuous, usually what I do, I will go with 1.25, subsequently I go with 1.5.
Dr. Sharma, this is Dr. Komakar from Bangladesh.
Yes, Komakar, yes.
Yeah, what is the EF of this patient?
Normal.
Normal.
EF is normal.
No. Okay. That will be a great case.
Yeah. So EF is normal, as you pointed out just now, that we did start with our regular, the Lima catheter, which we do. But every time when the wire went to the mid loop, it pushes out the guide. Now, initially we were thinking about the AL 0.75, but in this case, we thought there is a proximal disease. So we didn't want to go into that. Although now we are taking the EDP also. EDP. Show the hemodynamics on one side, please.
Do the EDP.
Yeah. Pressure is good. So since we are there, we are showing that little elevated, which is from ischemia, but it's the beat dependent. So not a major issue. Yeah.
Okay.
Good. It definitely is elevated, which is probably representing the significant ischemia on this case. So now we are going with the AL. Now we didn't go with the AL because you see there is a proximal lesion. Yeah. There is a slightly proximal lesion in this case. So we know that anytime the AL will touch that lesion and will be damped. But I think there is no choice. And second, otherwise we could use Akari 1 to get little extra support. Yeah.
What is your
now?
Sorry.
What is the wire is now using?
No, right now, earlier we had a fielder wire, and fielder wire went to the second tortuosity. But then, despite the fielder and fine cross, it just pushed out the guide 2 times. So therefore, now we are changing the guide. So now we are with the AL. As I said, that you can get a AL Akari 1.5 because AL is not making the right turn. It's a AL 0.75 with a long sheath. As you can see, we always use the long sheath in the complex cases. So wire in original, we start with the fielder wire.
On this no torque. You have the 3DRC.
No, I think if you want to going with the Akari 1.5.
It's
It's pushing out, yeah.
Soft.
No, Akari will be okay. So this is the AL is not making the turn at all. So let's try the Akari, and otherwise question is, can you do a 3D RC or no torque?
Get the 3DRC ready.
Yeah. Okay.
You understand?
Because
Give the wire.
It does not give support.
No, extra backup.
The
We
other,
do have that, but recently we've been using. I really find, though it's extra backup, not an easy guy to work with.
yeah. Okay. All right, let's see. So even the guide for the challenge, which we expected, because this we knew that it would have been
We may have to go back to
the no torque.
Lima itself. And
Yeah. No, this will be very good. Yeah. We'll taking out.
soft tip. LAO. Good.
There's a little anterior takeoff that, and we see the whole aorta is calcified. And it's not even a renal failure patient, but this is probably dependent with the age. All lesions are heavily calcified.
Okay, now.
Hmm.
No.
You want to put a wire first to change? No. Let's get guide
No,
full of
maybe a
dye a
no
little
torque.
bit. Yeah. Okay. Look for an, no, let's see this one. Ready?
Mm.
No. Yeah. Good. Now. Good. Okay. Just leave it there.
Yeah.
Yeah.
It'll
No,
fly
but
out again.
yeah. Okay. Go. So just not a great support, but let's try this.
I need a new fielder.
Yeah, new fielder wire. So otherwise, but the other question could be, I think the guideline, the 3DRC will not work. So we have the guideliner ready. We'll be able to use. Only problem is with the guideliner, unless you use a 7 French, you cannot put any rotablation burr. Although with a 6 French, tough time, we have seen you can put the orbital atherectomy can go with a 6 French, usually with a guide, but in order to do rotablation through the Gargilla or guideliner, Gargilla and same, that you will require 7 French. And 7 French can take up to 1.5 bar. But as rarely you can front load, 1.25 can go through the 6 French, but I have not been successful much, so I usually don't advise that at all.
Sir, may I comment, sir?
Yeah, of course. You continue comment.
Actually, for some cases, because there is definitely, as you said, osteoproximal, there is significant lesion.
Yeah.
Even sometimes it's very difficult to negotiate with even guideliner also. And what we do in such cases, very tortuous anatomy, because it's a catheter is not giving a backup for amplats, even JR is sitting nicely, the Akari is sitting. We also use the microcatheter. Slightly go deep so that you can negotiate the wire too deep into the EDR PLV. That will give a good support. Nicely negotiated. I think wonderful demonstration of the wire movement.
Yeah. So same, because remember you have to put a wire before you can put your microcatheter. See, guide is going out. Yeah. So key is, so now question only comes is, if sometime proximal mild lesion, I say that if need to be stent first. So establish your proximal support, and so that you are able to advance things. But I think this will be okay.
Means,
No, guide may need to go a little more.
No, hold on. I'm advancing.
Yeah, guide will be all right. Yeah, this will be okay.
We may not be able to do this.
No,
Is
no.
Rota.
Yeah, it will. Okay, after we do, leave it there. Rota wire. It will be okay. Yeah.
Did you clean it?
Yeah. Tip. So this one you need to go with a floppy because the extra support clearly is used in about only 10-15% of cases with the osteal disease or ISR because it definitely will give you more wire bias because of the tapering happens in long segment. So now this was the fielder wire. We are taking this out. As you can see, and now going to put the rota wire. So question is, start with a 1.25 bar first. So this one, if we need to upgrade, we upgrade later. But many times the wire bias will work even with a small bar to our favor, and we'll start if need to get a second stage. The ups bar we can always add to maybe 1.5 or so. So let's see where exactly we are. Should we give a little die? Yeah, in the small branch. We need to go to the cranial view. Let's go to that view first. Yeah, so there is a PDA, moderate disease of the PDA, but most important is the big posterolateral branches and AV. So right now we are in the PDA.
Yeah.
Question is that you want to leave it in the PDA or? I think that will be okay. Yeah, I would leave it in the PDA right now. PDA is good.
PD has disease. That
Yeah,
was only
osteal disease, that's okay. We can always do the balloon if necessary there.
Okay. Let's go with the bar.
Yeah.
I think we do 1.5
Yeah.
itself, right?
No, 1.25 now. Get 1.25 ready, quick. Yeah. This case 1.25 first.
Okay.
With those all the tortuosity and so on, I know a lot of people believe 1.25 doesn't do the work, but I can tell you these kind of cases 1.25 is the safest. Any opinion, and we can ask the people also to put the chat question that birth sizes versus where would you use a 1.25 bar. Very tortuous. I still think the 1.25 gives you less chance of perforations and dissection, and more importantly here much plaque ablation. We never do now the plaque debulking, but plaque modification.
Godzilla ready right now.
Yeah,
After this.
yeah, we have that. So therefore, question comes is that do you go with a 1.5 bar versus 1.25? So I think maybe we can ask our panelists, and Preeti, you tell us, Sanjeev, what would you do? And in terms of the bar sizing from 1.25 versus 1.5.
In such a badly tortuous artery, so 1.25 bar is the first choice. And after 1.25, we can do imaging with the IVUS to decide about whether we can upsize to a 1.5 bar. Dr. P?
Definitely. Definitely, I agree with
Compliant.
this tortuous
Compliant balloon first.
vessel.
Yeah.
1.25 is the
Can you
best
guys?
choice. And then we
Moving.
can, then we can see if we can park a balloon and see whether it dilates, and then we can upsize. But I think pushing IVUS in this might be a difficult task sometimes. Yes.
Yeah.
Exactly.
And you mentioned 1.5 bar is the right choice. Why? Because it's a very long segment lesion, lot of calcium block. When you go with the bigger size bar, it generates more debris. Heat generation is more. Slow flow, no flow, very high. While negotiating also, because the abnormal tortuosity is there, because it can hit the side wall and it can lead to perforation. But 1.25 create a track first, then so that even distally there is a very, very tight lesion. That is beyond the tortuosity. 1.5 is the ideal thing, so that you can reach the target. Once you create the passage, you can upsize or you can go with some other modality.
Yeah, that is absolutely correct. And see that is a big guide is not great support. So we are very cautious. And of course, we have two of our fellows here, Danijan and Frank. So we have actually 10 international fellows for our program. And they are very efficient and proficient in doing it, rotational atherectomies and orbital now. But this is a complex case. So this will be the type of case, even without even this kind of live relay, that myself or Anu will do it. So we now right there. So you are at the ostium, so that's okay. So key is that trying to push it out may be trouble. So that's okay. You make sure that it does not jump, which did not, and you can advance slowly, just at the tip. We're not going to touch it.
Would you screen to make sure there's no looping of the wire in the aorta?
Right. So they're basically push and pull, appropriately push and pull. If you know that you are able to advance, then nothing will happen. Yeah, good. Yeah.
135.
And pull back all the way. So key is the push and pull. If your guide starts coming out, that means your wire started looping. So have to be careful with that. So this is 1.25 patient tolerated so well. Now, once you go to distal lesion, give now atropine and aminophylline. Give.
130. 5 seconds.
Yeah.
130. 10 seconds. 130. 15 seconds. 130.
Okay. Now you show the handle. So no, remember this gives you total about 90 millimeter of ablation. Now this is for distal lesion is like 150. So now we have to go forward. So what we do basically is first, no, 1 second, bring the advancer knob to the back and advancing this sword and tight it. So now on the Dynaglide with the brake release, rather than coming out, we are going to go forward. It's going to jump a little bit back, which is fine, but then manually advance. Go.
Dyna.
Yeah. May not go.
Leave it. That's why everything is not a pullback. Remember, I left it in the.
Good.
You have
Yep.
to leave it there. What we'll do is we go to the somewhere here.
Yeah.
That's all you can do.
Okay.
Now you go on Dyna.
Good. Okay.
Okay, do
Go
it
again.
again, yes.
See this brake release. We are going forward. If we could go.
Okay, stop.
Yeah.
Then we have to go a little bit further. 130, 120, 125, 5 seconds. Okay, let's see here.
Okay. We'll try again. Go. Because there is no good support from the guide. No.
Yes. Okay. Stop it. Let's make the bend and see. We'll do it on Dyna. Good. Okay. Ready?
Yeah. No. It's all with the guide. We have to bring the guide. And can we guide telescope a little bit more? Pull. Pull and advance.
I'm pulling back and advancing.
Okay,
Okay,
good.
that's all.
Let's try now.
I think we went.
We
few
might reach it.
millimeters.
Yeah.
I don't know.
That's the guide a little better. Pull the guide. Good. So I think we might do it now. So because we need to reach to the
See, that's why I wanted the wire in the RPL. We would have had a better wire purchase. But
there is already ST changes. We are given the atropine.
120.
Yeah.
125.
Just went through that lesion. Senate now. Yeah.
10 seconds. I don't think we should do 1.5.
No. Yeah. Okay. So let's see now.
Okay, let's come out.
And as you can see, that patient tolerated with atropine and aminophylline combination.
Get me a run through. And then the Godzilla ready.
Yeah, the Godzilla also.
What percentage of RC-PCI with Rota you do without PPI?
About
7%?
30. No, about 30%.
About 30%. But key is that more and more, remember in the past we never thought about it because we always go for the groin, you put a pacemaker. Once you do a radial, and we actually published our data in AJC about radial rotablation versus femoral. And what we found is they actually lower, of course, bleeding and somehow lower complications. Now, is it because with simpler cases we did is a little issue, but overall the radial still works quite well for the rotational atherectomy. Let's give a little medicine first. Yeah. So key is now using this aminophylline combination, very common. Good. Let's go with the wire.
So PDA flow is gone.
Yeah. No, but that's
It was
just
subtotal, yeah.
yeah. That will come back. But there is definitely ST elevation. So in this case, now we are going to give some vasodilators. What is this? Nipride. Okay. Little nipride.
No, I would not give. It's borderline blood pressure.
That's
okay. Leave it. Once you open the vessel, the STs will go down.
Yeah. Give one of Neo. We want to keep our blood pressure a little high. systolic pressure in 100, give 2 of neo. So our nurses are expert, the same little different, our the set of nurses which will take care of the complex cases, and they will manage the heart rate, blood pressure without even talking to us, because they have the whole system set up. Get the balloon, the Gargilla, yeah. So we had done 1.25 only, and now we are going to go into the posterolateral branch.
You have to open the PDA first, no?
You want to go to epicranial? Yeah. That's okay. Let's go with the balloon. Yeah.
Okay.
But rota wire has to come out.
No.
No, Gargilla first.
You want to go through the both?
No. ST elevation, I think we'll take the rota out. Both will not go through the guide. Rota wire has to come out unless you put both in the together.
That's what I was thinking we need with the thing. Okay, let me take it out.
Yeah. Yeah. So key is that if you have 2 wires and you're putting a 6-point Gargilla, which is 5.5 French, you have to put both of them through the Gargilla. That's the only way it will go, if you want to. But in this case, now wire has come back a little bit. This is okay. Let's go in a little more.
No, I think there's a problem with that.
Akari will go take it. If we need to open it, unless it's a bend somewhere.
Yeah. Hold on.
No.
Hold here.
What happened here? This is bent?
No, that's not the bend.
Yeah, it's a bent. Get a new one?
Yeah.
Yeah. Give us a new, this is the wire broken. Yeah. Okay, give us a new Gargilla. Yeah, so what happened is the wire interaction with that Gargilla deformed it. We are going to go with a different one.
Though the inner diameter is no different, mark guides are way better when you're doing this complex procedure.
Yeah.
This is a new guide extension, Guide Plus, from one of the Japanese company. That's very low profile, very easily negotiable through tortuous bands. And in India, most of the labs are using it, Guide Plus.
Yeah, I saw that. And the only thing is, remember, it's a very radiolucent also. You can see sometimes, no?
Yes.
Okay. So, and of course, we had to go with the balloon.
I would go.
So
Okay, everything came out. You think we need a 2.5 regular balloon?
We have, that's what we have, compliant balloon, yeah.
12 or 20?
20 will go. So, yeah, good. So this is the run-through wire now. Let's get a balloon through. Need little support. Yeah. Pressure is okay, little ST elevation, which I expected with that slight slow flow in that PDA. Okay.
I would have gone 12 balloon. So let's advance.
It's a 2.520 compliant balloon. Yeah. Good. Let's advance the wire now. Okay, we need to go to that view, so we know we are in the posterolateral.
No,
that is
not
3720.
I think you have to open the PDA if you want the STs down.
Okay, this is the PDA.
Going to a smaller branch. Yeah.
Yeah.
Oh, you want to go to that view?
Okay, just 1 second. We go to 27 and cranial 20. Good. This is the PDA. Yep. That's okay. Let's get the. Now we are going to just telescope. Any questions from our audience? Okay. We are going to advance our Gargilla, which will be a big issue here because going to cause tremendous ischemia in this vessel. Good. I'm going up.
Only other question, did we have to pre-dilate the proximal?
Okay. Let's go back then.
So, yeah.
Yeah.
Down.
Yeah.
Actually, yeah, inchworm technique works.
Yeah. No, we wanted. We thought that we may get to the distal one, but since we could not, so we had to do definitely pre-dilatation. The proximal is a compliant balloon. Yeah.
Well, deflating, we can advance so that we can.
Yep. Get a 2.5 12 high pressure also. Ready? I'm going up here.
It's a chat box.
I'm
there are few
deflating.
questions you already answered.
Okay.
They are asking, in such a badly calcified artery, do you do it without TPI? We have already discussed.
Yeah. Good. Go.
And,
I think we go 3, 5, 12, high pressure and open the
Okay.
proximal.
Yeah.
Then only
3.5
get-
12 high pressure. Good.
because that
Yeah, proximal area has to be opened.
Nodule.
Yeah.
There may be some nodule that.
No,
is
there
preventing-
definitely.
Yeah,
Now, first we need to take care of that lesion. We are not sure it's nodule. It
Yeah.
could be just a calcific lesion.
Yeah.
So now what we'll do is we'll go with the 1-to-1, which is 3, 5, 12, high pressure, and then
Maybe
try to
stent it.
get the
And maybe stent the proximal. Stabilize.
What
Nothing
about,
wrong in
that.
using sir, what about using the angioscope to further modify the proximal portion so that you can create more cuts and you can.
Yeah. So
negotiate?
clearly
No, right now you see, you
The
have to
cutting
remember, we are struggling even with a regular balloon and a wire.
Yeah. So they're unlikely to go.
Yeah.
The Wolverine or angiosculpt or Circumflex. But here right now we need to take care of the proximal segment first. So we learned that. Because even Gargilla is not going because of the proximal disease. We actually had to pull back.
Okay. Now,
No, pull back more. We have to, because lesion is a little proximal, so we have it good. Yeah. Yeah,
yes,
this is the one.
that was the one that was.
So this is the 3.5 12 at 20 atmosphere. Of course, it's not fully open. We
No,
can decide
I
later
think
on.
it's
Yeah.
okay now.
Yeah.
I think it's even.
I'm going to go up and then you'll advance
No,
now.
I think it will go now.
Yeah. Good. Usually advancing on the deflated one is good. Right. Yeah.
So that was telling us that the lesion
That
proximally was
8.6.
significant. You needed to dilate that. And for that, you need 1-to-1
If
balloon
you can
size,
advance a
high
little bit
pressure.
further, this
No,
one we can do
first-
proximal segment. No, mid RCA we can do with this balloon if you can go.
The first is I'm trying to see if I can wire more. Nothing is
No.
working. Okay, so let us go with the 3, 5.
Yeah, yeah. Okay,
Now we-
I'm going up.
Okay, let me advance.
Mhm.
Wait. Okay. Every movement is very hard.
Very hard. Yep. Good.
Now, if somebody decided they wanted a balloon pump in this case, electively
Yeah. Let's go.
would have been okay too. So you want, let me advance the same balloon further. Now that the wire has gone, it may not make the
No,
turn.
this will not go. We have
We need a
compliant
new
balloon.
balloon. Yeah.
No, but guide and you want to advance a little more. I'm putting a balloon up.
Okay,
One
go.
second. Yeah. Get our 2.5 balloon which we had earlier ready. Or you want to go with the 2.5 12 now?
12,
12.
new balloon.
New balloon. Yeah, you had 2.5 12.
Okay.
Non-compliant will go
I
now.
think
12. Yeah. Good.
it moved distally. I think still it can be done distally.
Yeah, so this is not going further because balloon did not go. That was a 3.5 12 high pressure. Did not go. So we brought to the mid area. Now we are going with a 2.5.
Okay.
Yeah, so we'll go clearly we need to go distally to advance. Good. Keep this, we may need later. Okay, this balloon. Okay. Yeah. Okay. And then now let's say and make sure that 2.5 20 compliant also clear because if we need to go to PDA, that's the balloon we are going to go.
I think the used balloons don't go anymore.
Go.
Okay. Good.
Okay, let's see. 2.512.
Is it semi-compliant or NC balloon, sir?
This is NC now.
Yes.
There's no semi-compliant. Remember, we sent it further down earlier. That was 2.520. So this is now the non-compliant, high pressure, NC. Good. Yep.
I think.
I knew that it will go there. It's a. You're too far. No, you're in the
No,
PDA.
I want in the PDA. Let's go to the
Okay.
PDA, open
Okay.
the PDA, and after that,
Good.
if the Godzilla goes down,
Good.
we stand the
Okay.
PDA first.
Fine.
Okay, now the wire. I don't know why the wire does not go.
Good. That's fine.
I think no, it's fine.
Yeah.
It's one of the branch. It went earlier also that way.
Yes, keep going to some branches.
Yeah. Good.
Okay,
Now it's the
we are
PDA.
good.
Ready?
It should stay there,
Yeah.
and we have to stand here. Okay, good. Stay
Yeah.
there.
8. I'm not going further.
No, I know. I'm trying to see if I can get the.
No, guide coming out. So I think we are not dilated those areas. We're just doing the PDA.
Down.
Let's do the proximal segment. The distal lesion.
Okay, go up. Distal is not a 2-5 vessel. Okay, down.
No. Have to pull back a little more. Yeah, here. Yeah, good.
Also, I think this. Oh, good. Now it made it. Okay, now we have to decide the. Let's get the stent for the PDA.
Yeah.
And just deploy it.
Yeah, good.
What stent you want?
Okay, let's take this out. I think the 2.520 synergy for the PDA.
Okay.
Shall we do a small injection to the guide?
Yeah, no, we'll see it. Yeah, definitely.
PDA,
We need to see
PDA
that
for-
where we are. Yeah,
If you're not sure, put a 24. Huh?
that's okay. Yeah. Yeah, Promus versus Synergy. We use knowing that they will soon stop making the Promuses and only Synergy, and Synergy Megatron will be available in India very soon.
So will be gentle injection, slow.
Yeah,
Yeah,
20?
nicely opened.
yeah.
20?
20 is good.
Yeah.
I want 24, so you know you just cover everything.
Okay.
Okay, 2-5-24 synergy. And then let's just start marching back.
Yeah.
3-5.
3.5.
3-5-38.
Yep.
I want
Okay.
48.
Yeah, 38
48.
or 48.
Yeah, it's all the way down.
Okay, or
Guys,
3.5, 48. Yeah. So so far looks okay. As you see there, nice PDA. So we're going with the 24, 2.5.
And also get us a 3-5-48 synergy.
So what is happening is one of our room is undergoing construction. So a lot of supplies are one versus 2.524 first. And then get a 3.548. Yeah. Now give this one first.
Three.
Yep. Now I can, somebody asked me if we say that what has been besides the guide wire and those adjunct devices, the greatest discovery of interventional cardiology, I would say this mother and child catheters. Can you imagine this case without it to be done? Will be failure. No matter you put a double wire, parallel wire technique, anchor the proximal wire with a stent and all that, decreasing the time and ultimately make it successful. This is it. Guideliner, Godzilla, and all those series which you say, Guide Plus.
Okay.
Okay,
Just a little dive. Okay. Make sure we are good at
good.
downstream. Yeah,
That's good.
Go.
Going up. 14 atmosphere.
Down. Now, ideally, we would have gone with 3-5 and just make sure everything is dilated. But since the Godzilla is all the way down, I think we take the advantage and put a 3-5-48 synergy stent, and then we can decide on post dilation.
Yeah, here.
And I
Let's
think-
go up. No, let's go up here.
No, you don't want that.
This angle. Go up angle. Yeah, get the stent. Okay. So let's make everything nicely open.
Okay,
Good.
down.
Yeah, that will be better.
We are going to stent it anyway, so there is no reason not to do this. Good.
I think we should not take a picture. Let's put a
Yeah.
48 and
48, then we
decide.
decide. Yeah. Then actually proximally you want IVUS is ready to go in, and we do it when it's appropriate. Clearly in this situation, which earlier somebody said we decide with the IVUS won't make a first turn. So time will come, we do the IVUS particularly for the proximal vessel, and we can show the Megatron, Synergy Megatron, which I was told that will be available by February or maybe March of next year. So that tells you that latest generation of Boston Scientific stents compared to our other competitors will be available in India at the same price, I think. You want to go a little more?
No.
Okay.
Please.
Okay, good.
Then you will,
Let's get the guideline out.
then you'll close the RPL, AV continuation. Okay, now
Yeah.
bring some. We have to give a little gap.
Yeah, they had to give a gap. Okay, I'm giving die. Good.
Uh-oh. Okay, ready?
Yeah, good. Going on.
No. I
You don't
think
need the
full
die.
power.
Then I think it's
Okay, go.
Okay.
This is 3548.
48, yeah. It's a Synergy XD. So basically it's the same stent, little better delivery. So in India, actually XD is not coming. It's coming the Megatron, which actually really, if you think about, you need the Megatron. Large vessels, 4.4, 4.55 with the dense, the tight cells and thicker. That really will, for left main, it's a very good idea. Large, bulky RCAs also.
Everything is looking so good, I would put another stent and then decide, right?
Yeah.
You want to put 3.5?
3.5, 48, another
38.
one. Okay, 3.5, 38. Yeah, see that, look at the guide catheter.
Expanded and everything is on our side. I would just see that. I'm just expanding, going back
Yeah.
and take the stent, deliver the stent, and then we can decide what to do.
Okay,
EKG is still, EKG is, I think,
much
improving.
better, yeah.
yeah.
That itself is telling us the flow is better. I know we're not given any dye.
3.5, 38, yeah. The patient is moving, a little more sedation, please. But just to say the guideline, again, the Akari guides, a lot of people do not appreciate. I do quite a bit PCI with Akari. One of the advantage of Akari is your proximal lesion. You're worried about the AL. This really gives you very good support. And this was Akari 1.5. 1 point, that would have been too small.
What do you think? 48?
You want to get 48?
Hold on.
48 is better choice. Otherwise, we
No,
miss
there is
the
a room.
option.
There is a lot of room. Yeah, there is room.
Oh,
Yeah, there's a lot of room.
exactly.
Yeah.
Too much overlap.
Now guide has to come out first.
First guide come out. We don't want to
Guide-
pull
guide plus.
too much. Yes. And then decide, right? No, extension is out.
Yeah, extension is out.
Okay. Now so give some dye. So I know how much I have to bring back.
At least 10 millimeter.
That's good, no? Okay, the dye.
Yep, good.
Yeah, good.
Going up.
It's
Look
fine.
for a 3.530 high pressure balloon also.
May not go.
No, will go.
Okay, good.
16 atmosphere.
Down.
Flare the ostium coming out. Good.
Now, what I will do is I will get the Godzilla down again on the balloon. Same, I think once you have stented, you should be careful when you are trying to advance Godzilla again over the balloon. There's a risk of LSD again. So just be careful here. And then we take our 3.5 high pressure balloon, post dilate, and then we can IVUS.
Then IVUS, okay. Okay.
EKG is better, completely back to normal.
Yeah.
So just the 1.25 bar did the job in the tortuosity.
And that is what you need. So I say what it really did. Did it do a plaque modification? No. What it basically did is cut the interelastic lamina. So remember, we could not even get a fine cross across this lesion. It cut the interelastic lamina, so whole vessel will expand. And that is what did, of course, took away that calcific arc, caught the cut in the calcium. Going up?
Wait.
Mm-hmm.
Expand. Okay.
Always think about the guide. I tell all the fellows, when you're doing this complex case, 3 things you have to see. Not only your device, where the guide is and where is your guide wire. Both of them. Excellent display of those, as you can see here. Let me go up and you bring your, yeah. So some people just look at the wire and then the guide is in the aorta. So whole purpose is defeated. So you have to have combination of 3. So 18 atmosphere.
Wait, say that.
Yeah,
No,
sorry.
still.
Okay. Ready? Deflate.
That's about it. I think
Yep.
we don't.
Ready?
After that, yeah. Wait 1 second. Let me get the. Okay, go.
Okay. 16.
And do here. Okay.
Good.
Here.
IVUS is ready, guys.
3.5 NC or 3
3.530. Yep.
3.5. We are going
Yeah.
between 18
What
to
is the
20
balloon name?
atmospheres.
3.5?
Post dilation.
Huh? Name. NC Emerge.
It's a Boston balloon.
Boston Scientific. I am the highest user of 30 millimeter balloon in the world, probably.
No,
People
no,
go
no,
to small, I use the biggest one. Ready? I'm going up.
There. Okay.
They don't make 40 balloon. Maybe if I can start using even 40. Because I usually go with the 32 millimeter stent, 32, 33. Yeah, going up now. Okay.
IVUS is ready.
Yes.
So I think do
Yeah,
the
that
IVUS
is,
and then a final picture.
No, picture first. Everybody waiting for the picture. What are you talking about? We had to take a
Can
picture.
go IVUS guided PCI. Yeah.
Actually, that was the top. Huh?
Dr. Sharma, you have
30.
you have ran the post dilation balloon size because initially
30.
we do
It's a
the
30 millimeter,
small balloon.
3.530.
Yeah,
Post
initially
dilatation.
we go for the post dilation is small balloon, but
Yep.
by seeing you, we are getting the more. In Bangladesh is 20 millimeter. We are using
Yeah.
the 20 millimeter balloon for post
Yeah,
dilation.
exactly.
That is the advantage of the guide gel. When the guide gel or guide plus is there, you can use the long balloon, you can wrap nicely.
Right.
And radiation you can reduce because the longer balloon, otherwise small balloon you have to give more dilatation,
Yeah.
more
Right.
more radiation.
What do you want now?
Exactly.
I was first.
I would go IVUS first.
Okay. All right. It's her patient. She wants to just do the IVUS, not the IVUS guided. So IVUS made it simple. So I don't know whether it's the procedure. I would say Rota made the procedure simple. Although theme today was a complex lesion made simple by IVUS. So I would just say complex lesions made simple by a small Rota burr and confirmed on IVUS. Let's see. Okay, IVUS on the main screen, guys, now. IVUS is going through the Godzilla. Okay.
Let it exit and then we'll be okay. Don't know whether it will make the turn. Distal turn, mid RCA, right? Okay, it's coming out. You understand why I said we needed because go down. Okay, let me get the all the way down. His K.
Yeah.
I think I'm getting up to the distal
Sure.
RC.
Because the limit is 100 millimeter. So we can start from here.
Yeah, we'll start here. Let me
Okay.
take the Godzilla
Yeah,
out.
in the
and
guide.
I think
Yeah,
we
okay.
should be happy if we get
Okay,
to
start
see
full
here.
work. It's coming. Yeah, completely well expanded.
Yeah.
Nicely expanded.
Nice.
Yeah,
Yeah.
can we move those pictures of the panelists on one side and let us
Yeah.
see also?
You see the calcium behind a stent, but a stent is well expanded.
Nicely expanded.
Yeah,
Luminal
great area.
is-
Yeah, this is the tortuous part.
Great
Yeah,
apposition
some
also.
eccentric
There
lumen,
is a
but
nodule.
the lumen, area is fine. Yeah, he has a lot of calcium
Leave him
behind.
alone.
This is great. Yeah, all stented, no gap. This is some big branch. Yeah, all well expanded. Yeah, no gap.
Floro, we are coming to the ostium now.
Not yet.
The guide should be
Got
out, yeah.
I saw there's some ablated calcium.
So the way we should do after this is take everything out and one final picture.
Now coming to the osteum.
Asif, what's the dye used so far? 100. No.
There's also some eccentric, but lumen fine. Okay.
Okay, good.
I stop. Yeah, all well expanded. Just the ostial is not covered, but good area. Like
Then
here.
the mid also are showing calcium nodule also.
Yeah, nodule, yeah. So I think they
Yeah.
take the guideliner out
But
and
this
take
is
a
ostium.
picture with the
But no
wire still
dissection.
there.
And a normal opposition.
Very thick
let's-
calcium.
Yeah.
Very,
Yeah.
very.
But same thing, nodule, I say, if your lumen is more than 5.5, don't be crazy because that's one going to cause perforation.
Yeah.
But your lumen is 5.5 or no, 7.69.
Yeah,
Yeah.
this is eccentric part, but area is 7.6.
Yeah.
Okay, pull back now.
Great.
Yeah,
Good.
it's
Ready?
perfect.
Good. Hold the wire,
You
hold
know what?
everything.
I'm
Yeah.
going to pull like this
Good.
so we can see the distal vessel. Okay, ready?
Yep, ready. All right, see to believe it. Whoa.
Oh,
Good. Wonderful.
I don't think you need anything else.
Yeah.
I mean, you can always touch up here and there, but it looks such a gorgeous, such a fantastic result in this 80-plus-year-old patient. I think it's to me, it's a big victory and victory of the live session, which is going to end in 2 minutes. We are on time. The complex case done.
Masterly presentation. Beautiful demonstration. Wonderful case.
Okay. All right. So Sanjeev, you start your lecture series, and I'll join you in less than 5 minutes upstairs.
Sure. Thank you, sir. Thanks
Okay.
for
Thank you
doing
very much.
Thank you very much.